All right. Good evening, everybody, on this Valentine's Day Eve. Thank you so much for spending time with us as we dive into an important discussion around sexual health. I invite you to take a moment to grab your partner from the other room and ask them to join us for the next half hour or so as we find these discussions are most impactful when we have the support of our loved ones. So a couple quick reminders before we get started. This presentation is totally anonymous. You're not on camera. Nobody can see your face or your name. And we do this because we want to have an interactive discussion. We want you to feel comfortable to ask questions. And even if you think they're embarrassing or you don't know the right words to say. So to maintain your privacy, you can write your questions in the anonymous chat box at the lower portion of your screen. And we'll save time at the end of the presentation to answer as many as we can. So we have about 45 people in attendance so far. So remember, if you have a question, somebody else probably has the same one, so don't be shy to ask. Our speaker tonight is Dr. Michael Kemper, who is a fellowship-trained urologist and men's health expert at Georgia Urology. Dr. Kemper has built his practice around helping men who are struggling with sexual health issues and helping to restore their confidence. Dr. Kemper, thanks for joining us this evening. These lovely folks are tired of hearing from me, so I'll mute my mic and turn it over to you. Thanks so much. Dr. Kemper? Uh-oh, looks like we have a little tech glitch. Hopefully Dr. Kemper will be right back. In the meantime, please stand by. Hang with us for just a minute, everyone. I see everyone still joined. Just give us just a second. Dr. Kemper will be right back and we'll get our presentation started. You are back.
That was a brief nightmare. I'm sorry, folks. One sec. Let me get my screen again and start this webinar. I apologize that unplanned sojourn from the scheduled remarks. So thank you guys so much for joining with us and for bearing with me. Let's just drop out again.
Dr. Kemper, your audio is breaking up a little bit too. Do you want to join from your phone and I can share the slides from my computer?
That's not a terrible idea. Is this working? Are we good? It disconnected.
No, your audio is not good, Dr. Kemper.
One man have ED in their lifetime. More than half of men over 40 have some degree of ED, and almost 40 million American men will have ED at some point during their lifetime. So the way that you get an erection, the process of it, is that the arteries, the brain sends a signal down the spinal cord to the penis. The arteries in the penis open up and let blood in, and then that compresses the veins at the outside of the penis and hold the blood there. And so you can have problems at any point along this process. ED can be associated with and caused by a number of problems that can occur over the course of every man's lifetime. So the vast majority are vascular causes. Diabetes is a huge risk factor for erectile dysfunction, as can certain medications, beta blockers, antidepressants, a history of pelvic surgery, including prostate cancer surgery, or nerve problems or endocrine problems like low testosterone. So, according to the census, over 15 million men in the US have diabetes, and diabetic patients are more likely to have ED, more likely to have severe ED that is not responsive to oral treatments, and can sometimes just present with ED. So, this is one of those things where folks with diabetes often have ED, and it's something that frequently needs to be treated. Similarly, heart disease is strongly associated with erectile dysfunction. So it's an independent risk factor for having a heart-related event if you have ED associated with your coronary artery disease or your heart disease. And you can get the ED first because those vessels are smaller than the vessels that feed your heart. So ED, the 50% obstruction, you can get some symptoms of erectile dysfunction. As you can see here, that penile artery is about half the size as the main arteries that are going to the heart, and about a third the size as the ones that go to the brain, and about a quarter the size of the ones that go to legs. So these are the ones that start to get blocked off first. And if you have that process happening in those arteries, it's definitely happening in the arteries that feed the penis as well. Low testosterone, another thing that's associated with erectile dysfunction. So that's when man's body produces less testosterone, either because the signals aren't getting sent from the brain properly, or because the testicles just aren't making enough testosterone. Some of those same things I just talked about are associated with low testosterone. Almost 40% of men over the age of 45, and every 10 years older you get, you have an increased risk, almost 20% of low testosterone. That is something that is associated with testosterone or with erectile dysfunction. It doesn't necessarily cause erectile dysfunction, but it definitely doesn't make it any easier. So, treatment options for low T, just to touch on that briefly. If you are diagnosed with it, there are gels, there are patches, there are pellets that we implant inside the body, there are oral medications, there are also injected medications. There's a lot of different ways to replace testosterone. Another thing that can cause erectile dysfunction is prostate cancer treatment. So the nerves to the penis course right over the top of the prostate. And so when the prostate is treated, either with surgery or radiation, those nerves and some of the blood supply can be damaged. And so prostate cancer treatments can affect the ability to get and maintain an erection, either temporarily or on a permanent basis. So almost 75% of men have some degree of ED. Everybody, honestly, after a prostatectomy have some degree of ED initially. That can get better over the first couple of years after surgery, but persists in lots of men. And almost over 50% of men who've had radiation will have erectile dysfunction. Peyronie's disease is another thing that can cause erectile dysfunction. This is a disease of scar tissue where, for whatever reason, we don't have a good explanation, people will have an injury to the penis that causes a exuberant scar tissue, almost like a keloid of the penis. And that causes a curve and can lead to difficulty having sex. That also causes some rigidity of that or some lack of stretch. And so people can get erectile dysfunction as a part of it. There are treatment options for this, either stretching devices, medicine we inject into the scar tissue, or even in patients with severe ED, as well as Peyronie's disease with a concerning curve, they can also do a penile implant. So how do we fix ED? There are essentially, I tell folks, 4 options. We got 5 on the slides. We'll talk about all of them. Ways to treat erectile dysfunction. And these are all options that work to some degree or another. Let's keep moving. So we got the next ones. We'll talk about them all in turn. So oral medications, you're all familiar with that. The little blue pill, Cialis, Viagra, they work by opening up the blood vessel to the penis and letting more blood in to give you an erection. They work for really, really well for people with mild to moderate erectile dysfunction. If you take Viagra, you want to take most men start with the pills. That's 100% where you should start. Um, we're good. Yeah, we're good.
You're here.
Almost half of men start on the pills. Eventually, they stop working. And men with diabetes, as we mentioned earlier, are much more likely to have to move on to another treatment. Intracavernosal injection. So injection medicines. This is a medicine you inject directly into the penis to give you an erection. It works very well, actually, better than the pills do. But most guys don't really like injecting themselves in the penis every time they want to have sex. It can cause some pain, some prolonged erection. Some people will get scar tissue buildup at the injection site. I get only about 4 keep with it long term. Most commonly, they'll stop either because it doesn't work very well or because they don't like injecting themselves. So the vacuum device that creates vacuum at the base and draws blood in. Then you put a ring at the base of the penis to hold it there. This works. It is something that most guys don't like all that much because it's a little cumbersome. You have to take the time to get it to work. It doesn't work well for people with a little bit of extra cushion because it's tough to get a good screen, a good seal to get the erection. And it can be tough to maintain. So I haven't had a lot of guys that really like it. I use it a lot in radical prostatectomy patients for rehab after surgery. But as a way to have sex, it is not a great one. Urethral suppository. So this is also known as Muse. I'm going to honestly, I don't like it. It most causes a erection and some burning with urination. I have not used this in any patient for a while. It's something that can be used if you don't like injecting yourself. Penile implant. So this is a device that goes inside the body that gives you an erection whenever you want. So it's a pump that goes in the scrotum, 2 cylinders that go in the penis, and a balloon that goes up in the belly. Whenever you want to have sex, you pump the pump. It gives you an erection. The erection lasts as long as you want. Whenever you're done, you press a button on the pump, erection goes away. So this is something that works very reliably every time you want to have sex. It's something that has a 90% plus patient satisfaction, 90% plus partner satisfaction. It's something that works really well. So this is, we've been doing this for a long time, over 50 years of some kind of a penile implant. More than 500,000 men have received it. This is not a new technology, although there's been some refinements and the current ones work better than anyone that's worked previously. It has an antibiotic coating, low risk of infection, very established technology that works well. So this is a demo of how it works. So you grab the pump and move the fluid. That moves fluid into that reservoir, into the cylinders from the reservoir, gives you an erection. And then whenever you're done, you press a button on the pump, and that moves that fluid back out. So we do these as an outpatient procedure. They take about 30 to 45 minutes. People go home later the same day. It's about a 2 to 4 week recovery period. 4 to 6 weeks, people are back having sex again. So there can be risks associated with any surgery. Mainly for this one, infection is a small risk. It's a mechanical device. It lasts usually between 10 and 15 years. If it breaks, we take it out, put a new one in. Not any harder to put a new one in than it was to put the first one in. Generally, we can get good insurance coverage. Vast majority of commercial insurances will cover it, as well as Medicare covers it. The VA will cover it. Medicare Advantage should cover it as well. So 90% plus partner satisfaction, 90% plus patient satisfaction, low infection, typically covered, lasts for 10 plus years for the vast majority of patients, looks natural from across the room. There's no locker room appearance. Nothing's outside your body. Everything's inside your body. So this is designed to maintain a natural appearance. There are some other things you may see or may hear about, or if you go to some of the clinics, you may get offered these on a cash pay basis. Shockwave, intracavernosal stem cells, platelet-rich plasma. All of these are in that sort of investigational realm. The evidence just isn't there yet that they actually work, and in some cases, the evidence is kind of bad as to whether or not they work. We don't offer them right now at Georgia Urology because we haven't found the evidence compelling enough to start offering it and charging patients for it. So thank you guys so much for listening and joining me today and bearing with us through some technical difficulties. It was a pleasure to talk to y'all. I am a resource for you guys. So if you have questions, I am more than happy to answer them.
Thanks, Dr. Kemper. I love that we're in urology and not technology. So, all right. Yeah. So Dr. Kemper has agreed to take a few questions, but I first just wanted to provide a couple opportunities for you to set up an appointment with him at one of his locations there on your screen. First, and potentially the easiest, is just take a picture of what you can see on your screen, call the office. When you call his office, you can let them know that you attended this webinar. We've set aside some priority appointment slots to work you guys in quickly. You can also visit gaurology.com and click on the orange schedule button, and that will allow you to schedule directly with Dr. Kemper as well. So we, as a reminder, we've got some questions coming in on our chat, so we'll go ahead and address some of those. So the first one, Dr. Kemper says, I've got some narrowing of the shaft at the base of my penis. Could this be Peyronie's disease? And if so, could it eventually cause ED?
It definitely could be Peyronie's disease. So Peyronie's disease, not always with a curve. Sometimes you will get what's called an hourglass, where there's scarring that narrows the penis. It can cause erectile dysfunction, or frequently people will have filling up to the point of the narrowing and then very poor filling outwards. The treatment for that, if it's an hourglass, you can do surgeries to treat that hourglass, or if it's something that is causing severe enough ED, frequently a penile implant is the best option for those guys.
I don't ejaculate anymore. How can this be treated?
So there are a variety of things that can cause an ejaculation or not ejaculating, or retrograde ejaculation, so ejaculatory dysfunction in general. The biggest ones that I see are people who've had prostate surgery, either prostate cancer treatment, so a radical prostatectomy will cause no semen to come out, because that's part of the job of the prostate, is it makes more than 50% of the volume of the ejaculate. Also, if you have radiation, similarly, you're not going to have as much come out or any come out. Surgeries for the prostate, transurethral resection of the prostate or green light, or any of them, honestly, that are for urination, will also make it so frequently can cause an ejaculation or difficulty ejaculating. Or you can also, if you're on certain medicines for the prostate, so tamsulosin is the big one, that can cause difficulty with it. Diabetes is a major cause of retrograde ejaculation. In general, if it's medicine-induced, we stop the medicine, and that can help. If it's caused by a procedure, that frequently is difficult to reverse, if not impossible to reverse. Similar for retrograde ejaculation that's caused by diabetes, caused by nerve damage.
All right, so I'm currently on a low dose of daily Cialis, and I also take an oral medication before sexual activity. I have low T and diabetes, and I'm 63. Are there any other options for me?
So we can try replacing T. It doesn't always help erections all that much. Usually it's much more with energy, libido, interest in sex. It can help though. The other options, once you're on, so that's the maximum of the pill that you can do. And so once that isn't working well enough for you to have sex when you want to have sex, your options are injections, a vacuum device, or a penile implant. Most guys in that circumstance, implant is their best option. Diabetes is by no means a deal breaker for that, although it is one of those things where the better control you can have beforehand, the lower your risk of infection.
Is ejaculation still possible with a penile implant?
It is definitely still possible. So that is something where this is not going to change the sensation of orgasm or your ability to achieve orgasm or your ability to ejaculate, all of which are not necessarily completely related to your erectile function. So if you can ejaculate now, you'll be able to ejaculate afterwards. If you can have an orgasm now, you'll be able to have an orgasm afterwards. As I discussed, there's a lot of reasons why men might not have ejaculation. This isn't necessarily going to bring that back, but it's not going to disrupt it in any way, shape, or form.
I think you touched briefly on this, but we'll visit it again. Does Medicare and a supplement cover the implant?
It should. Medicare will cover it. Everyone's deductibles can be a little different depending on if you're on an Advantage plan or anything like that. But they definitely, we have no issues with getting it covered by Medicare.
So looks like, should I address my testosterone issues prior to moving forward with implant surgery?
Not necessarily. I don't think so. If you have severe ED and pills are not working for you, then testosterone is most likely not the reason for your erectile dysfunction. It is something that you have together. So you have low testosterone and erectile dysfunction. You don't necessarily have low testosterone causing erectile dysfunction. While we can certainly supplement your testosterone and see if that works, and there are men that choose to do that, I would be a little surprised if you have ED that's not responding to pills that suddenly gets rescued by pills when you start on replacing testosterone.
Can a penile implant interfere with urination when soft or hard, or does it interfere at all?
It should not interfere particularly with urination. I have had guys, so if in some men who have leakage of urine due to having a history of prostate cancer surgery, it can occasionally help that somewhat if they inflate the device slightly. But for the most part, it should not impact your urination. This is not going in the same area.
Oh, this is a good one. Do many men over 80 get penile implants? That's a great question.
Yes, I have had more than a few patients over 80, and actually, I have had some of the guys that it's been the smoothest, have had the smoothest recovery, have been over 80. Every man is different, and not every man looks their age or acts their age. Not that there's anything wrong with that. You don't suddenly stop wanting to have sex because you get older. And if you are healthy enough to have sex and healthy enough to have surgery for it, then it is something that is an option and something that I've done on men.
We have so many good questions in here tonight. Okay, so some of the pills like Viagra give me an erection, but it doesn't seem to last very long, 5 minutes maybe. Is there any solution to this?
So it's not so much that there's a solution. Well, there is a somewhat of a solution. So that happens either because there's also some degree of what's called venous leak, where the veins are stiff, and so even though blood is coming in, it's not compressing those veins shut, and so while the blood is coming in, it leaks back out. You can't maintain it there, or there's just not quite enough blood rapidly coming in for a long enough period that it maintains it. One thing you can try with that, if you're able to get a really good erection, but it doesn't last, and you want to prolong it, is similar to how those vacuum devices will have rings that maintain the blood there. You can do the same thing if you can get a good enough erection with Viagra, that can help maintain blood. You put a ring at the base of the penis to hold it there. and that can help a lot in terms of prolonging that. It does mean you have to put the ring there, and you have to don't ever put anything on that you can't cut off, but it's something that can work well to help that.
Can you talk a little bit about the difference between the oral medication? So it says he's used Viagra before and it worked somewhat well. And he used injections that worked really well, but he wants to know if there's something like Cialis or another option that would work better than the Viagra.
So
Whoops, that one just sent him right over the edge. Let's see if he comes back. Well, we'll come back to that question. We'll give Dr. Kemper just a minute. We've got some really good questions in here tonight. Thank you for your engagement. We want to get to as many as we can, so hopefully Dr. Kemper will be right back and we can keep addressing some more. To the gentleman that asked that question, hang with us. We'll be right back and we'll make sure that we get your question answered. Hey, Dr. Kemper, you're muted, but we can see you. We can see you here.
I will stop the video because I don't have my nice background, but I'm still here talking. So Cialis works more where it's about it takes about 2 to 3 hours to have a full impact. It doesn't matter if you eat or not beforehand, but it will last in your system for about 24 hours. And so that means that some guys can find that they can take a pill at night and have it still work the next morning or later that day. Also, Cialis is available in a daily pill that works actually pretty well for people with mild to moderate ED. And some guys find that if you take a pill every day, even though it's a pain to take a pill every day, it really improves the spontaneity of it by not having to time stuff out and really worry about, oh, I have to know I'm having sex in an hour so I can take my pill and I have to not eat dinner.
All right. Thanks, Dr. Kemper. Is seed implant treatment considered prostate surgery or does it fall under radiation? It's kind of a unique one.
It's radiation.
Okay.
So when we're talking about surgery for prostate cancer, we are typically talking about a radical prostatectomy, so removal of the whole prostate gland. Seed implants is a form of radiation, either with high dose where the seeds are put in temporarily or with low dose where they're put in permanently.
All right. Could previous BCG treatments have caused ED? Could you explain that a little bit more for us?
So BCG is a treatment for bladder cancer. It is unlikely that would in and of itself cause erectile dysfunction. Now, there are certain things that make people more likely to get bladder cancer, namely smoking and tobacco use, that have a huge impact on erectile dysfunction. But BCG in and of itself is not likely to be a solitary cause or even really a contributor to erectile dysfunction.
Does the penile implant add length or girth to the size of your penis?
Oh, I wish. So this, unfortunately, erectile dysfunction robs you of length. So people will lose about a half centimeter per year while they have permanent severe ED. And if you have your prostate removed, you might lose 1 to 2 centimeters of length. A penile implant can prevent you from losing more length. It does not typically give you length back. It will give you a little bit of girth back, and it will certainly maximize your girth and your length. But I can't make it. We can't make it like you're 25 again. We can just work with you having the best of what you've got.
Is there a preferred treatment for someone who's had seed implants done previously?
It all depends on the severity of the ED. Everything is on the table in those patients. So pills if they work. If pills don't work, then injections or a vacuum device or a penile implant, all of which are certainly options.
So I tried one of the oral medications and it caused a rapid heartbeat, which kept me awake for a while, but did not result in an erection. Is that a typical reaction from an oral medication?
The rapid heart rate can be. The not getting an erection can be. It depends on how severe the ED is. So one thing we can do in that circumstance, sometimes we can do some more diagnostic studies if people are having issues to try to tease that out. So we can do what's called a penile Doppler ultrasound, where we do an injection in the clinic and then measure the blood flow into the penis. And that can help us get a better idea of how severe the problem is. And we can kind of make a decision from there whether the pills may not be just working well enough. There are other versions of the pills that sometimes people will tolerate more. So I have Viagra is one of the least specific ones. It was the first one developed. So sometimes people will find that they have fewer side effects from Cialis, or that they have fewer side effects from daily Cialis than they do from an on-demand pill that's a higher dose.
Very good. I had the Resume procedure 2 years ago to treat my BPH. Can I still get a penile implant?
Certainly, you definitely can. None of the prostate treatments conflict with our ability to do a penile implant at all. Radiation doesn't conflict either. Surgery does not conflict either. Really, the only thing that makes you not a good candidate for a penile implant is if your diabetes is very poorly controlled. And in most circumstances, if you can then get it under better control, and when I say a better control, my cutoff is a hemoglobin A1C of anywhere under 10, but in an ideal world, in the 7s is great, then you are a great candidate for a penile implant.
This is a good question. Why are pills not as effective after taking them for a few months? Do you notice that in your patients?
I can't say that I have necessarily noticed that it's always difficult to say whether that's progression of the disease. I don't think your body should get habituated to it particularly. I've certainly had a few guys say, well, it stops working. Usually that's because the disease progressed and not so much because the pills just stopped working. There are also interactions or how you're taking the pill. So sometimes people will take the pill in one way and then not, or the timing won't work as well for some of them. I have not seen that they just suddenly stop working, though.
Could a previous back surgery, an L4, L5 fusion, could that contribute or cause my ED?
It can certainly contribute. So spinal cord injuries, back injuries, all of those can impact the nerves, the ability of the signals to get sent from the brain down to the penis. So it can be contributory. It's more common that we see vascular ED than spinal or neurogenic ED, but it is possible.
All right, so I can get an erection, but it's difficult to maintain, and the pills don't seem to help that much. What's the next best course of action for this patient?
Trial of injections, trial of a vacuum device, or a penile implant if the pills just don't work well enough. Or if it's a patient that doesn't have a good reason to have vascular ED, it might be worth doing a blood flow study and seeing if there's anything else that's contributing to the erectile dysfunction.
All right, so if I'm taking a blood thinner, will I need to stop it before surgery?
Yes. So you should stop if it's Eliquis, about 3 days before. If it's warfarin or Coumadin, it's usually about a week before. And if needed be, you talk to your doctor about who's managing the blood thinner about bridging.
All right. What type of surgery options are available for an hourglass type of Peyronie's disease?
So mainly it's surgical, and there are basically two broad speaking options. There's what's called extracorporeal. So if there's no erectile dysfunction in this circumstance, then it would be either extratunical grafting. So that means you put a piece of graft over the tunic, over the sheath that surrounds the penis to fill in the space without cutting into the penis. That's something that works really well, best for hourglass deformities, for people where there's still straight and there's no curve. You can also actually do a graft where you open that up and put a graft over the top of that area to bring it back a little bit. That is a higher risk of erectile dysfunction, though. So we would generally prefer, if someone doesn't have a curve, you can get stability just and fill in the space just by putting in a graft.
Do you find that your patients say that injections are painful?
Yes. So we use insulin needles. Most people don't notice the injections so much. Most people, it is something that is more psychological, getting over the fact that they have to give themselves injections. But when we do it in the office, the most people will say, no, it wasn't nearly as bad as I expected it to be, but it's difficult for me to do it if they're not able to do it. The pain is more that each of the medicines that we use, so I usually give a medicine called Trimix, which is a combination of 3 different medicines. Each medicine will cause an erection, but at higher doses can also cause significant penile pain. And so we give them sort of at different lower doses to try to get a good erection without causing pain. As you need to step up in the dosage and need more, that can lead to having more difficulty with pain.
Very good. I think we've got time for just a couple more questions. So maybe you could talk a little bit about delayed orgasm. What could cause that?
So that can be so getting older definitely causes that. Worsening penile sensation. People with diabetes can definitely have difficulty with that. Hormone issues can cause that. There's no FDA approved thing that treats that, although there are various things that we can use to try to treat that. There's various medicines, either a medicine called cabergoline, which works centrally on dopamine, or oxytocin can be given, or there's other things that can be used to try to help with that a little bit. Also, in some cases, it can be something that needs sex therapy, can help a lot with that in patients that are younger and don't have an organic reason for it.
Can my partner feel if I have an implant?
So your partner can feel, if they're feeling your scrotum, they will be able to feel the pump to the that feeds the implant. So we want that to be in a position that is easy to feel so that you can inflate your device easily. The penis itself, they should not feel, it should be a good rigid erection, but it shouldn't feel obvious that there's an implant in there.
All right. So what's the difference between your office and the men's clinics that I hear on the radio or on the billboards around town?
So the men's clinics are not staffed by a urologist, and they're certainly not staffed by a urologist with training in male sexual medicine, which is what I am. They are typically not offering all treatments. They steer people towards the treatment that makes them that is cash based typically, and is not necessarily science or evidence based. We are able to take care of you on your whole process as a whole patient, including other medical problems that are urologic problems. We have extensive training, and we're urologists. We're not just solely focused on that sort of men's health clinic.
All right. So can a penile implant be safely removed and replaced?
It can definitely be removed and replaced. It can be removed without causing any, it can be safely removed from a life and limb standpoint. If you get a penile implant and it needs to be removed for whatever reason, you can't just then go back to doing the pills or the injections. They are not likely to work as well. And people can get some scarring and some contraction if the penile implant needs to be removed. But if it fails, it doesn't necessarily need to be just removed. It can be removed and replaced. And if it's not working, but it's still there, it doesn't necessarily need to be removed unless it's causing trouble.
All right. Are loose clothing or undergarments required if I were to proceed with a penile implant?
Only while you're healing. Once you've finished healing, you shouldn't be looking very much different than you were to start with. So in the initial healing period, I actually tell people to usually use compression shorts to try to hold everything high and tight while they're healing up. But once you've finished healing, from across the room, no one can tell anything. There's nothing hanging out. There's not a whole bunch of extra parts. There's nothing that's like an impression. Everything is completely inside the body and completely concealed.
All right. So if I have a weak erection on oral medications, can I just simply increase the dosage?
There is a max dosage that you can do for the pills, which is typically 100 milligrams of Viagra, 20 milligrams of Cialis, or the absolute max is 5 milligrams of Cialis every day with 100 milligrams as a booster of Viagra. That is the most amount of pills that is safe to take. So you can increase the dosage to the max, but once you're at the max, you can't keep going.
All right. So I've seen some early signs of ED. Is there anything I can do to prevent it from worsening?
Yes, you can quit smoking, do as good of a job as you can about eating healthy and losing weight, maintaining good blood pressure, treating your diabetes if you have diabetes. All of the stuff that you should be doing anyway is extreme. It's good for your body. It's extremely good for your penis as well. So if you have the beginning phases of erectile dysfunction, anything you can do to improve your overall health will certainly keep that from speeding up.
All right. We've got just a couple more. So how long is the hospital stay for surgery?
There isn't one. It's about 4 hours from you walking in the door to you walking back out to go home. I don't typically keep people overnight after surgery. I keep typically surgery takes me about 30 to 45 minutes, and you go home later the same day.
And you can't beat that. All right, Dr. Kemper, I got asked this question earlier and I saved it to the very end because it is the day before Valentine's Day and this doesn't get any more romantic. So is it okay to bring my partner to an appointment with you?
Please do. It's good to talk to everybody, and it's good to get everyone's perspectives. And this is a decision that if you have a partner, your partner should be extremely involved in, because they're going to be involved on the other side. So everyone, it's better if I talk to everybody and if everyone knows what's going on and everyone is invested, because honestly, this is something that can restore a lot of spontaneity to relationships, can help with a lot of that things that might have been lost after treatment for prostate cancer or managing diabetes. And, it's not that you aren't the only one that has the problem. The couple has the problem. And so it's good to address that with your partner and to be able to talk about what can we do together to fix this.
Very good. I had one last one that snuck in. What hospitals do you work out of? We'll leave them with that.
Yes, I operate primarily. I do penile implants at Emory Decatur, Old DeKalb Medical. I also will see patients near the Emory Hillendale office or the Piedmont Rockdale or at Northside Atlanta on occasion, although I tend to do the vast majority of my surgeries are at Emory Decatur.
Excellent. Dr. Kemper, thank you so much for your time. Wow, we have had such an engaged audience tonight. I certainly appreciate you guys investing this time to learn about how you can restore your sexual health. And thank you, Dr. Kemper, for spending your evening with us. We appreciate it, working through all these technology issues we've had. We hope you'll join us again at some point in the future when we do some more education on these important topics. Dr. Kemper, I'll turn it over to you for any final remarks before we wrap.
Thank you guys so much for joining us and for joining me on the tonight, for bearing with us through some technical issues, and for all your awesome questions. Hopefully I can see you guys in the office sometime soon, or one of my partners. But we are happy to see you and I'm so glad that you were here today.
Thanks, everyone. Have a great evening and a happy Valentine's Day.